quickly, this was the link to the pretest, and if you were able to take it, you'll have a little foretaste of what we're going to talk about today, and then there will also be a post-test, and that's really just for you and for Area LAHEC to see if this was worthwhile at all to assess your learning. And that's also something that, as part of the North Carolina Board of Occupational Therapy approving a course, they require that we have some kind of assessment of learning built into the course. So this is a demonstration of that, and I hope it's not just a formality. So we're, if you want to refer in the future to the handouts, so there's an agenda that'll have the case studies on it, and then the PDF of these slides, that link right there, I'll just leave that there for, a while, months. So you're welcome to go there and fetch those resources anytime you like, or share it with friends. So the objectives for this hour that we're going to talk about, we are going to talk about what happens, what are some of the ethical and relational and emotional sort of factors or dimensions when the provider, the occupational therapy practitioner, and some other member of the team, whether it be the client or the client's family or maybe even another discipline, when there's disagreement over the need for OT or the type of OT that's being or the intensity, right, the frequency or the duration. And this we'll talk about here in a minute why this especially for y'all who are there together, maybe we could just take like 5 minutes, very quick minutes. If you could just reflect, the handout with the agenda and that Google link has this table, and you don't have to necessarily write this down, but if you could just reflect on from your practice setting, and I'm not sure where, if y'all are an inpatient or outpatient, or it'd actually be great if you were representing a variety of practice settings, but have you recently or ever experienced disagreement over the need for occupational therapy? And maybe just share 1 or 2 instances of that, or if you've had some kind of disagreement with a team or a family or a client over the type of service that was being offered, or maybe even the intensity. And by intensity, again, I mean frequency, duration, or location. So if you would just take a few minutes and kind of brainstorm what are some examples of that from your own practice where you encountered disagreement. And then in really, like, let's say 4 minutes, I'll start my timer now, let's be ready to share. And I don't think I have control over muting you all, so you'll just, when it's time to share, if you could just unmute yourself. So I'll just be quiet for a couple of minutes. All right, so that's been about 3 minutes. If you all are ready to share, you can go ahead and unmute, or if you need a little bit more time, maybe just let me know. Maybe somebody type a note in the chat box down here. I'm doing a webinar. I'll come by. Are y'all there?
Yeah.
All right, so any thoughts about this? Any examples from your practice about where there's been disagreement over the need for OT or the type of OT?
Do we put it in the chat box or just talk to you?
You can just talk.
Oh, okay. Yeah, I've had many years of experience of in inpatient OT trying to stress the daily needs of ADLs due to strokes or head injuries and those kinds of things. That's probably in the biggest obstacle, honestly, was a lot of the physicians, the older physicians that weren't still familiar with occupational therapy and, you know, and the need for it. Their comment would be, well, you know, physical therapy can do that. They do everything. You know, that was
right. So that's really good. Yeah, that's a good point. That yeah, sometimes it's just a real lack of understanding about what occupational therapists do that drive the disagreement.
Correct.
There's a question, can the folks from Nash hear us? And are the people that are gathered together in Nash County, can you all hear? Can you unmute? And Jenny, I'm going to let you troubleshoot that.
Sure. It's showing muted on my end, so I don't know if they know how to unmute themselves. So I'll check on that.
Okay. Y'all, for the folks that are gathered to unmute, there's a microphone icon. In fact, if you're looking at the screen, I'm circling it right now. If yours is red with a line through it, we're not going to be able to hear you. So you just click on that, and when it turns green, we'll be able to hear your comments. So I'm going to continue moving forward.
Computer, okay. Okay, we're here. Sorry about that. Okay.
Yay! Yeah. Welcome. Did you all want to add anything to this? Any examples from your practice settings where there's disagreement over services?
We had a current example of a patient who's been coming to therapy for a long time, and he's made really slow progress, and he's right at the cap as far as what his insurance will cover, and he wants to continue despite the fact insurance may not cover. His wife doesn't want them to continue because she doesn't want them to be left with the bill, and we're kind of sitting on the fence trying to figure out, you know, how much functional progress he can continue to make.
Yeah, so that's another really good example, and from my practice setting as well, which is schools, that issue of slow progress or no progress is often the place where practitioners across healthcare disciplines run into this question of, does therapy need to continue? Yeah, and when that's the question, that is, I would say, the #1 instance of disagreement. So let's keep both of those examples in mind as we move forward.
How about in the school systems, when the occupational therapist typically recommends 1 to 2 times a month in therapy? Can you hear me?
Yes, absolutely. Keep going.
1 to 2 times a month in therapy for fine motor control and writing skills and those kinds of things. And the parent thinks and wants they should be seen 2 or 3 times a week. With a comment coming back is that, oh, well, we teach the teachers and the aides how to train the kids to work on those skills in the classroom. So what do you do when you have a comeback like that? I mean,
Yeah,
as far
so
as what I'm saying. Go ahead.
yeah, so our project here today is not to necessarily resolve these conflicts,
Yeah,
but to give you
right.
tools to resolve them on the ground. But I will just say, in that case, what you're offering us is a really good example of this, when there's disagreement over the intensity of service. And in that case, you're going to see a little bit, that's often a place where both sides need to be really open to being educated by the group or the party or the entity that's in disagreement with them. And so, like in that case where maybe the school team is offering a lower level of service than the parent thinks is necessary, there's going to have to be a lot of like mutual back and forth education about, and we'll talk about this. Let's use that example when we get to talking about what are some ways to resolve conflict, okay? Okay. Great examples. Thank you all. So why this topic for an ethics session? Disagreement over the need for service is the #1 across healthcare professions, the #1 reported ethical dilemma by healthcare practitioners themselves. When they're asked, what's the most, what's the thing that you deal with most in terms of an ethical issue, and very often this is seen in healthcare, more sort of traditional healthcare settings, and often with end-of-life decisions, right? But how long do we continue a service, whether it's end of life or not, or how much service, or what type of therapy, what sort of theoretical framework the therapist should be using with a particular client. All of those things can be contributors to disagreement. So just to say, this is the #1 reported ethical issue that healthcare practitioners are saying they're facing in the field. So there, and you've in your examples, you provided examples of each of these 2 main categories. The first category of disagreement is the communication-based disagreement, which is essentially people aren't seeing eye to eye because of either poor communication skills or efforts on either side of the disagreement, or that one or both parties is not dealing with the full information set. And I would say that example of when the parent is looking for a greater intensity of service than a school team is offering, that would be probably a communication-based disagreement. And then there are organization or process-based disagreements, and this is where there are system barriers that prohibit or limit desired interventions. And the example of the insurance benefit no longer covering OT when in fact one or more of the stakeholders wants services to continue, that would be an example of a organization or a process-based disagreement, right? It's not necessarily that people are, the people involved disagree on the need for service, but there's something within the system that's prohibiting services either to continue or to stop. So what are some of the ethical issues that we face when there's disagreement over the need for or the type of service or the intensity of service? So as occupational therapy practitioners, as licensees in North Carolina, we have a moral obligation to ensure that clients are making adequate progress toward desired outcomes. And one of those examples you provided earlier, that this sounded like it was a questionable feature of the case, where the client was making slow or no progress, and what is our moral obligation in that case? All team members, we are also obligated to ensure that everybody has a decision-making voice and that they're informed about student progress. We want team members to have all of the resources and the information, the data that's required to provide high-quality interventions. We need to ensure that all policies, laws, and ethical codes are upheld, and our profession from the national level through our the standards we use to prepare occupational therapies practitioners for work in the field, and even our code of ethics and our licensure board standards say that occupational therapy is a client-centered practice. And I just want to take a second to talk a little bit about how client-centered practice is a little bit of a problem when we're talking about disagreement over the need for services. So this is taking you back to like your grad school days, right? Client-centered practice. Oh yeah, what does that say? So it says that the client is responsible for being an expert in their own life situation, in articulating their values and their hopes, and they are responsible for teaching those things to the OT. The client gets to be the assigner of meaning about, they get to name what matters and what doesn't, and they're the ones that choose the goals that they want to work on. And in some settings, happens. This is also a system barrier in lots of other settings. Client-centered practice would suggest that the client gets to choose the professional with whom they work. So on the OT side, on the practitioner side, the OT or the OT assistant, the practitioner is responsible for being sort of aware of themselves, for creating an environment where the client can lead and pursue the goals that the client's chosen. So this is rather a facilitative rather than directive approach. And that also means that the practitioner has to be like at least prepared for requests that are unexpected or outside the scope of evidence or expertise or standards of practice. It doesn't mean we need to provide them, but our commitment to client-centered practice does make us vulnerable to some, say, odd or even inappropriate requests. The reason that becomes troublesome when we're thinking about disagreement over need for services, and when we're thinking about the relationships that are established in the context of client-centered service or client-centered care, especially when we have multiple stakeholders. And I don't think there are very many practice settings where it's just the OT or the OT assistant and the one client working together. And usually there are a team of healthcare practitioners involved with the client, and at least one other family member, like the example you gave, the wife is also a stakeholder in this conversation or in the disagreement, right? So when there are multiple people involved, we begin to get a little confused. Whose autonomy is at stake? Who is the client in the client-centered practice? So our client is certainly the first priority, but they may not be able to make their own healthcare decisions. We have an intervention team often, which is comprised of other therapy disciplines or a physician who's managing the client's overall care. But that intervention team isn't always the direct recipient of OT services. That's the client, right? But in client-centered care, we've got this sort of ethical commitment to the intervention team having a strong voice in intervention decisions. And in many cases, like in schools, the IEP team would be that intervention team, and they actually have a right to accept or refuse the recommendations of the OT in terms of interventions. So we might have a caregiver, and they may have a different perspective than the client or other team members about the need for or the type of service, and then the OT themselves, right? And so they have their own practice to sort of be accountable to and for. They often have resources, equipment, space, materials for which they're accountable and responsible, and there may also be supervised personnel. Which is all to say that client-centered care is, or client-centered practice is easy to conceptualize when we just are thinking of one client and one therapy practitioner working together But it's rarely that simple, and particularly when there's disagreement. And so I'm just suggesting that our commitment to client-centered practice gets a little troublesome when there's disagreement over the need for service. Some other relational dimensions to keep in mind are that there may be bias by either or several parties, and that can disagreement can be either heightened or ignored based on bias related to age or race or gender or any of those different diversity classes. And unfortunately, many of those biases are hidden to the people that are holding them. So we often operate from a bias without having any conscious awareness of it. We might kind of frame this situation as, oh, that's a difficult parent, or that's a difficult family, or that's even just a difficult client. And it's interestingly, in the literature around the disagreement for services, on both sides, when there's disagreement over healthcare decisions, attributing psychological issues to the group that is disagreeing with you, like I said, on both sides, the client and the healthcare side, that's a very common and one of the first things that people do, which I just found very interesting. And the family or the client may be coming from a history of difficulty with the healthcare system or a particular provider type, such that they're entering into the disagreement from a place of distrust. Also, access to information, data, knowledge, and just in general, decision-making power imbalances also contribute to some of that relational dimension of disagreement. And then, as you know, if anybody has had a recent argument with, say, a family member, right? We in all walks of life, we disagree all the time, and but the stakes seem and feel and are experienced as higher when there are healthcare decisions, or in our case, the need for therapy, right? So important to know that strong emotions, this is helpful for me to, when I read it, it was like, oh yeah, that's absolutely true. It's not something I'd ever seen articulated, and most of this information that we're about to get into as we begin to think about managing disagreement comes from the dispute resolution literature. So strong emotions can have the appearance of carrying greater moral weight. And isn't that true, right? The more angry somebody is, the more sort of justified in their position they feel, and or that somebody who's listening to their argument, the more impassioned they are, might be prone to think or persuaded to that side, right? So there's also an emotional landscape of working with, and I think that case of the client who had been in therapy for a long time, there is an emotional layer to working with a chronic or slow to improve or even worsening condition. And that really needs to be named and acknowledged. So a couple of different kind of categories of emotion that I'm going to suggest, and you're going to see here later, again from the dispute resolution world, we're starting to sort of change our tune about what to do with strong emotions in the context of disagreement. So when the emotions that are being displayed include things like anger, frustration, impatience, anxiety, those can be real indicators that somebody is feeling like they're not being treated with enough sensitivity, like they're experiencing a lack of empathy. And these feelings of anxiety, anger, feel very justified. They tend to be pretty immediate and can be, in the context of a disagreement, really hard to manage, right? They often just shut down future fruitful conversation. right? So those are the kind of the hot, immediate response to disagreement emotions. And then there's these, I think, a little slower to develop and maybe longer, like, held moral emotions, which are things like indignation, resentment, a sense of injury. And these are indicators that offenses have not been named, right? And they're often driven by an experience of invisibility, or when there is a sense that there's a profound power imbalance. Okay, which is all to say that different emotions, or sort of different like categories of emotions, can be clues for us about what's going on and getting to the heart of the matter, which is what this next few slides are really about. The dispute resolution experts are beginning to really advocate for this notion that you are not going to find your way to resolution of a disagreement until you embrace the emotional experience of the people involved in the disagreement. We've got to engage it in order to move through it. And this has not always been the approach to dispute resolution. So we got to recognize these strong emotions or feelings as they are without trying to adjust them or tone them down, right? We've got to name them, almost ennoble them, so that we can figure out like how they are situated within the conflict. Let those emotions be a guide to what's really going on here. They're clues, right? They're symptoms that have a reasonable source. Whether the emotions themselves and the way they're being manifested is appropriate or reasonable, they're coming from some reasonable place, right? So we, the suggestion here, probably the new like approach in dispute resolution, is don't run from these big emotions, but also don't let them like get out of hand or let somebody act inappropriately or just go on a 10-minute rant. That's not what I'm suggesting. But especially in the West and especially in the U.S., we do sort of have this bias of decorum, right? That like there's a certain level of just, yeah, decorous like comportment in the context of a disagreement that everybody needs to adhere to in order for a productive outcome to be achieved. And that's we're finding is not the case. So in fact, in lots of dispute resolution, like seeking consensus over the disagreement about the need for services, folks are even like moving away from ground rules in order to give space to some of these strong emotions. So to engage disagreement, we've got to engage those emotions. The goal, everybody needs to like say it together. What our goal is to reach a consensus resolution here. And by consensus we mean a resolution that we can all live with and publicly support, right? And to do that, we've got to avoid this notion, this thing of bullied acquiescence, which is not consensus. Bullied acquiescence is when one or more of the people involved in the disagreement just kind of say, okay, fine, I agree. And then they leave the meeting where the resolution is being crafted, and it doesn't take long for the person who has been bullied into acquiescence to either sabotage the decision or not follow through on whatever the consensus resolution terms were, right? It just, the point is that when people are bullied into something that looks like consensus, it doesn't last very long. It's not a sustainable resolution. So to avoid those things and to achieve consensus, we've got to everyone envision a positive outcome. To not enter like a disagreement thinking, oh, this is going to be terrible, this is going to be a 2-hour meeting, you know, reframe to, okay, what's it going to take for this outcome to be satisfactory to everyone? So like I said earlier, this often means that everybody has to make room for being educated, not to state their case, but to listen and be educated. And that this is what this means is that people have got to be committed to problem solving versus position taking. And this is really hard. And I would say at this point, when we've got disagreement over the need for services and it's reached a point of, real disagreement, it really is important to have a skilled meeting facilitator, right? Especially when people are digging in and kind of sticking to their position. Like, there is no way I'm going to stop seeing this client. This is too important, and the client, say, wants to stop therapy. And people sort of dig in and hold their like opinion, their position, and when that happens, negotiations tend to break down, right? So the trick here when people are starting to sort of take and hold positions is to move deeper, to kind of dig under why are they so stuck with that position? What is it that they're concerned about? What's underlying? What do they really want? And it's often when we dig a little deeper behind those positions that we're able to find common ground among the people who are disagreeing. So, like I said, this kind of summarizes again, if we're going to engage disagreement over the need for services, we've got to seek understanding versus merely hearing and waiting to provide our own rebuttal, right? We need to very articulately name the problem. One of the biggest barriers to resolving the disagreement over the need for services in the literature is that people haven't really articulated what the issue is. So that's really an important first step, is to make sure everybody is working on the same problem, and to then not accept a superficial or first formulation of the problem, to really dig what's bothering you about this. What do you really care about here? We've got to work to build generous interpretations of the people that are disagreeing with us, and on the flip side of that, to avoid assigning sinister motives. And this is also a very common response when somebody is disagreeing with us, to just to assign and make bigger the sort of the egregiousness of their disagreement. It is really important to work in the particularity and the current moment, the current situation, to keep it small and concrete and specific, right? And to limit the number of separate sidebar conversations, parking lot conversations when disagreement's happening, to really keep the conversations that are related to the disagreement, to keep them kind of contained. So what do we do? How do we enter into this disagreement in a productive way? So some questions that will help the healthcare team, the occupational therapist, as they work with a client. Where are we going with this client? How are we going to know when we get there? How long do we think it's going to take? Where does our hope lie for this client and this family? What kind of possibilities can we imagine? What realities and challenges can we name? Whose future are we most concerned with? Those visionary questions kind of tend to take people's eyes and ears and feet off of their dug-in position. This just can be really, it can let some air, particularly when a disagreement over the need for services is kind of in a stuck spot. These vision questions can help open up the conversation. And then are the expected outcomes of the disputed intervention? Does everybody understand what's being asked for or what's being proposed? Does everyone share that view? Can we figure out how to frame this from the client's point of view? Is it related to or required for occupational performance? Sometimes it's, that example of the physician thinking that a physical therapist could do the work or not really understanding what an occupational therapist does. This question about occupational performance can be very orienting. Is the intervention that you're considering that's being disputed, is it realistic and measurable? Can you tell if it's going to be effective? And is it in alignment with theoretical approaches that the OT involved is competent and comfortable applying? Does it make sense in terms of task analysis of the desired outcome? And is it something that the OT can actually offer within the standards of practice and their own competence? Right, so this gets a little more technical in terms of questions related, but it can really, again, sort of, it can help once those strong emotions are named, then it can allow us to be a little more rational about what is it that we're actually disagreeing over. So, you all, if anyone was able to bring up the handout in that Google folder, all three of these case studies are on that 2-page document. Trying to think without that. So there are 3 case studies here. One is about constraint-induced movement therapy in the educational setting. That's one. Another is about a sensory room in a psychiatry unit. And then the third one is about exiting services. And I think this is from maybe from a home health or rehab. Oh, no, it's a, so it's an OT's providing services in a group home. So the idea here is, let me just pull this up. So this is what the folder looks like, the Google folder, the link that I showed you at the beginning. And like I said, you'll have access to this. If you want to use this document and these case studies, say for, like a professional learning community, staff meeting, an in-service, you're welcome to do that. So the idea with these case studies is that you'll read one of them, and I guess they're not printed here. I'll copy and paste them so that you'll have them for the future. But to read the case study, and then to identify the ethical, emotional, and relational dimensions of the situation, and then state, do that naming, okay, what exactly are the people disagreeing about, identify any positions that are being taken, and then what might be next steps as the team moves toward consensus resolution. So what I'm going to suggest is, since we have so few people on the call, could we, as a group, pick one of these case studies to work on, and I'll just leave it on the screen, and then you can read it, and then once you finish reading, I'll bring those questions back up. So would you all like to work on the disagreement over the OT, in this case, wants to keep services and the team wants to discontinue? Do you want to consider the case study about the establishment of a sensory room in this psychiatry unit, or do you want to talk about constraint-induced movement therapy being proposed in the educational setting? Which of those 3, 1, 2, or 3, would you like to work from? Y'all let me know. Unmute and let me know which one to put on the screen.
Let's go with number 3.
Exiting service. Okay, so when you are done reading this, just let me know, and then I'll bring those questions back up, okay? Everybody done reading?
Yes.
Okay, so somebody help us see what are the potential ethical dimensions of this situation? What are some of the ethical issues you see here?
Patient safety.
Okay, good. Patient safety, what else?
The fact that the team cancel services based on family demands versus the patient's needs.
This is the data about student performance. I mean, excuse me, client performance. Exactly. Right, so some ethical problems about the process, some ethical issues about safety, anything else you see ethics-wise? Okay, so this is, we're just reading like the OT's account, right? We're just reading one side of, and often this is the way, well, even if it was like a supervisor or a manager or a dispute resolution professional who's engaging, they're going to hear somebody's side first. So we're hearing from the OT. What are some of the emotions you can infer here that the OT is experiencing, and maybe even some of the emotions that the family or the team might be experiencing?
OT has frustration.
The OT is experiencing some frustration, did I hear?
Yeah.
Yeah. What else?
Some worry for patient outcomes.
Yep. So anxiety, frustration. Remember, those were some of those first responder emotions. And remember, those can be indicators of somebody feeling like there is either some insensitivity and or like sort of lack of understanding about the situation. So these emotions might help us with this OT, like this just might be a indicator that we got to make sure that everybody on the team is working from the same set of information, the same set of facts, the same data set. What about the family? Any emotions there that we could infer even? Hard to say. Go ahead.
They're probably frustrated as well.
Yeah, I agree.
I think it's a certain degree of not having quality education regarding what they're seeing and what's happening.
Right.
To the family. Yeah, for the family to understand.
Right. Right. So you guys, you're doing the good work here of using what potential emotions people could be experiencing to sort of figuring out what are those emotions telling us, right? Good. Okay. How about the relational dimensions? Any relational dimensions that might be different than the ethical or emotional ones?
It could be that the OT may be requiring the family to be more involved with the feeding, eating situation, and the family does not want to be bothered.
Yeah, it could be that. There could be some cultural preferences or expectations about how mealtime goes for that family that the OT doesn't understand. Yeah. Again, all of this pointing us to everybody on this, everyone involved in this disagreement needs more information, needs mutual education like we talked about earlier. Good. Yeah, and even this OT using that phrase pushy family, right? Again, sort of assigning a sort of a character trait to this family that isn't necessarily flattering. That the need to do that, or the reason that the OT is doing that's coming from somewhere. Let's use that as a clue to how we might open up some common ground. Okay, so can somebody as concisely as possible name the source of this disagreement?
Communication-based.
I'm sorry, can you say that closer to the phone or a little more loudly?
Communication-based.
Yeah, definitely communication-based. So let's go ahead and articulate what is it exactly these people are disagreeing about. I agree, it is a communication-based disagreement. One sentence, and this is going to feel kind of like duh and common sense to say, but it's really helpful to be able to say in as few words as possible, what is it we're disagreeing about?
I would say patient needs.
Right. The disagreement is over whether this client needs occupational therapy intervention during mealtime, or to become more independent and safe at mealtime, right? And this is not about intensity or even the type of interventions that are being, this is just very basic and fundamentally, is OT going to be involved with this client's mealtime performance, participation, progress? Okay, Kate, do we see any positions being taken by any of the stakeholders here? What are they?
Well, the family's being adamant.
Yes. Adamant, the family is adamant that this client needs to be left alone during mealtime. Right, that is the use of the word adamant there would indicate a position being held. What about the OT? Maybe not as strongly, I don't know. Okay, and so remember, if we've got one or more stakeholders taking a position, we want to use that position and we want to dig a little deeper so that we can find some common ground. So for this case, we would want to ask, you know, what's your concern about your family member receiving support while he eats? What about that bothers you? What about your family member receiving assistance or therapy while he's eating that makes you uncomfortable? Or what about his current participation and performance during mealtime? Are you satisfied with? Has you sensing that he is safe and independent enough, right? So using that position that somebody's taking as a place to start asking more questions, not in a accusatory way, not in a way to demonstrate or kind of dismantle their argument, but to really be curious about why are you there? Why are you there in your thinking about your family member? And to use that as a place where we then try to seek a consensus resolution. So finally, what steps might be a good next step for this situation? What could the OT do next?
One of the things I'm missing in this scenario is the group home staff.
Yes.
I'm not seeing anything from them.
I'm sorry, say that again?
I'm not seeing any kind of comment or interaction from them.
Yeah,
that makes you wonder what support they're giving this client and or family or OT. I'm just concerned about the group home staff.
That's a really good point. And so remember, you all suggested that everybody in this situation needs more information. And yes, more information that we might need is exactly what are group home staff doing during mealtime for this client. The OT seems to have a sense that the group home staff is still needing a considerable amount of support and coaching. How is the group home staff feeling about that? Right? Yeah, so definitely more investigation. So that might be, so somebody who's maybe facilitating or looking into this disagreement might have some, a next step might be to go talk with the group home staff that work with this client during meals. Excellent. Any other suggestions about next steps? Okay, well, we are here at the end. I don't know if you all have a device where you can take the post-test now, but I think Jenny was going to email this link to you after today's session, and then you can go ahead and take the post-test. I will send her the results from both your pre-test and your post-test, and then she'll have record of everyone that took it. If you have, that's some references there for you, and those are also listed on the handout in that Google folder, which again, the link for that if you want to get, and I think Jenny also sent you the slides, the PDF of the slides, so you have that already. But
Yes.
I really appreciate y'all's participation today. Is there any kind of concluding comments or questions?
Thank you, Lauren, for helping with this.
Absolutely. Yep. I'm glad to continue to work with Area LA HEC. It's been really, really smooth, easy process to do this today.
Okay.
Great. Thanks.
I hope it was helpful.
It was.
Jenny, do you have some final words for this group?
As you just spoke, I will be sending the email with that link, and you'll also receive an email from Ariel with your evaluation where you can print your certificate of attendance. So that's it. Thanks again.
All right, then. Yeah, thank y'all. Bye.
Bye.
Thank you.